Hello friends, this is Nishant. I am here with the next video on ECG, and in this video we are going to talk about PR interval and QRS complex. That is this area, that is PR interval and this QRS complex. Now the ECGs and diagrams that are used in my video were borrowed with permission from following two websites, ecg.utah.edu and ecglibrary.com. These two are very good websites if you want to practice additional ECGs or learn about them in detail. Let's move on and talk about PR interval. Number one, how is PR interval measured? So PR interval is measured from the beginning of P wave to the beginning of QRS complex. There is one more term called as PR segment, which is measured from the end of P wave to the beginning of QRS complex. This is PR segment. Now, I want you guys to remember that PR interval is clinically more commonly used term than PR segment. So it is quite important to spend some time on PR intervals. So normal value of PR interval is 0.12 to 0.20 seconds. That is 3 small boxes to 5 small boxes. Now there can be number of variations in PR interval. Let's have a look at them. Number one is prolonged PR interval. Now these three things mean one and the same thing. If you want to remember, I would just advise you guys to remember that PR interval of more than one large box is considered as prolonged PR interval. That is, if you are seeing that P wave starts, then it ends and then QRS complex starts, and if this is more than one large box, it is prolonged PR interval. Then it can be seen in heart blocks, acute rheumatic fever, where it is one of the minor Jones criteria, and sinus bradycardia. Then shortened PR interval, that is PR interval of less than 0.12 seconds or less than 3 small boxes, is seen in sinus tachycardia or Wolff-Parkinson-White syndrome. I talk about WPW syndrome in detail in my lecture on arrhythmia. Then there is something called as changing PR interval. What happens in complete heart block is P wave keep coming at their own pace and QRS complexes keep coming at their own pace. So what happens that there is no relation between P wave and QRS complexes, which causes a bizarre looking ECG in which you will see that there is no constant PR interval that is continuously changing, that is seen in complete heart block. Let's interpret this ECG. 1 second. Alright, number one rule that I want to give you guys is that PR interval should always be measured in limb leads. So you guys might want to completely ignore these leads while measuring PR interval. Let's have a look at how PR interval is looking in limb leads. So I want to look in lead 3 for that matter. Say here PR interval begins and it ends very well before end of one large box, which tells me that this is a normal PR interval. In a sense, this ECG, if you look for other abnormalities, they are absent. So in a sense, this is a normal ECG. Let's practice one more ECG. I'll take a 1 second pause for you guys to interpret this. Alright, I want you guys to focus on these beats on this ECG. Now let's start marking the PR intervals. Number one, in first beat PR interval is this. In second beat PR interval is this. In third beat PR interval is this. And in fourth beat, however, we see only P wave and it is not followed by a QRS complex. So there is progressive prolongation of PR interval and a missed beat. So can you guys remind me of a condition in which there is progressive prolongation of PR interval and a missed beat? We haven't gone through it yet, however I am going to talk about it in detail in my fourth lecture. Yes, you are correct, it's Mobitz type 1, second degree heart block. Mobitz type 1 second degree heart block. Let's have a look at one more ECG. In this ECG, I'm going to take a 1 second pause for you guys to interpret it. Alright, let's start marking the P waves and the PR intervals. This is a lead 2 where we are marking P wave and PR intervals. So this is one P wave, this is one P wave, and immediately followed by it is a QRS complex. So this is a PR interval. This is one more P wave and this is a QRS complex. So this is a PR interval. And this is one more P wave and this is a QRS complex. So this is a PR interval till here. Then there's one more P wave right here that is superimposed on T wave that again doesn't get conducted. Then there's one more P wave and this is a PR interval. So you guys can notice that in this case PR interval is constantly changing. There's no one value of PR interval. So can you guys remind me of a condition in which PR interval is changing? It is complete heart block. Let's interpret this one ECG before moving to the next area. Now I am going to take a 1 second pause. Alright, let's mark P waves and PR intervals. This is a P wave and you can see that this is a PR interval which looks significantly shortened, and perhaps the initial part of QRS complex is slurred like this, which is also called as a delta wave. So can you guys remind me of a condition in which we see shortened PR interval? We saw two conditions, that is sinus tachycardia and WPW syndrome. Now I want you guys to remember that delta wave is a characteristic feature of Wolff-Parkinson-White syndrome. Again, I'm going to talk about it in detail in my next videos. So this is an ECG of shortened PR interval that is seen in WPW syndrome. Let's move on to the next part of ECG, that is QRS complex. Number one is, the question is, QRS complex denote what? So QRS complex basically denotes depolarization of ventricles. Ventricles have three parts. Number one is septum, number two is mass of ventricle, and number three is the basis. Depolarization of each one of them is recorded differently on an ECG. So depolarization of septum is recorded as a negative deflection, that is Q wave. Depolarization of mass of ventricle is recorded as a positive deflection, that is R wave. Depolarization of the basis, however, is recorded again as a negative deflection, that is S wave. So this is QRS complex is the combination of these three waves. So I have what I have written here is Q wave for septal depolarization, R wave for ventricular mass depolarization, and S wave for depolarization of base of ventricles. Now oftentimes you will see that waves are indicated either in capital letters or in small letters. So what does that mean? So if the amplitude of wave is more than 0.5 millivolts, they are recorded as capital letters. If the amplitude of waves is less than 0.5 millivolt, they are recorded in small letters. That's all about it. Then there is sometimes you see something called as a secondary R wave. So after S wave, sometimes what you see, if this is R wave, this is S wave, sometimes you see a second positive deflection. So this is R, this is S, and this is labeled as R dash. So R dash, capital R dash or small r dash, is positive deflection after S wave in QRS complex. If the deflection is more than 0.5 millivolts, it is capital R dash, and if it is less than 0.5 millivolts, it is small r dash. Luckily for us, there is only one abnormality of QRS complex, that is a broad QRS. That is defined as a QRS of duration more than or equal to 0.12 seconds or more than or equal to 3 small boxes. Let's look at few examples of this and interpret the ECGs. Now I'll take a 1 second pause for you guys to interpret this one. Alright, let's begin from the basics. You see upright P waves in lead 1 and lead 2, and each P wave is followed by a QRS complex. So this is an ECG in sinus rhythm. Now if you were to look at the rate, if this is the first QRS complex, this would be 300, this would be 150, this would be 100, and this would be 75. So the rate is between 75 to 100. So an ECG in sinus rhythm with rate between 75 to 100, this easily is a normal sinus rhythm. So it's essentially a normal ECG. Now let's move on to the next ECG. I will again take a 1 second pause for you guys to figure out the abnormalities of ECG so that you can pause the video and have a look at it. Alright, I want you guys to focus on V1, then on lead V3, and tell me if you see a normal duration of QRS complex or abnormal. Yes, you are correct. If you mark this as the beginning of QRS complex and mark this as the end of QRS complex, you can say that this is definitely more than 3 small boxes, or at least equal to them. So which tells us that this is a broad QRS. Now what else do you see? Say this is the first positive deflection, so it is R wave and it is less than 0.5 millivolts, so I am labeling it as a small r. Then there comes a S wave, that is again a small negative deflection. Then there is a positive wave called a secondary R wave that is indicated by capital R dash. So this ECG is showing RS R dash pattern in lead V1. So it will come again in future in the videos of bundle branch blocks, but if you see a RS R dash pattern in V1, it is indicative of right bundle branch block. Again, I am going to talk about it in detail. At this place, the purpose of this ECG is only to show you guys a broad QRS complex. In this ECG, I am going to take a 1 second pause for you guys to interpret. Alright, let's see. So let's look at the QRS complex in any lead. Say I'm looking at lead 1. For example, if this is the beginning of QRS complex and this is the end of QRS complex, you can comfortably say that it is definitely more than 3 small boxes, or at least equal to it, which tells us that this is a broad QRS. Then you guys can see that again in this ECG as well there is a RS R dash pattern, perhaps small r dash in this one. So R, then S and R dash, again indicative of conduction delay in the right bundle branch block. We will talk about it in detail in the lecture on bundle branch blocks. Other abnormalities in this ECG can be interpreted as a tall peaked T wave. Can you guys remind me of a condition in which we see tall peaked T wave? Yes, that's correct. It's hyperkalemia. So when in hyperkalemia, when you see an ECG at extremely high levels of potassium, you guys can see broad QRS complex arrhythmia, that is also called as sine wave pattern. So this is an ECG demonstrating hyperkalemia. Thank you so much guys for watching my video. If you like my video, please subscribe to my channel. I will be posting series of videos on ECGs and other topics in upcoming weeks. If you have any questions, concerns or doubt, please feel free to reach me at love.intmed@gmail.com. I want to thank Dr. Frank Yanovich of ecg.utah.edu and Dr. Dean Jenkins of ecglibrary.com for allowing me to use their ECGs. Then I want to thank two of my best friends, Dr. Pranav Patil and Dr. Aditya Tolat, for their valuable inputs in designing and modifying this presentation. Here comes the mandatory slide. I like to conclude all my presentations by the next slide, by remembering the motivation for me to come in the field of medicine. My uncle, late Dr. Sanjay Tiwari. I used to call him Dr. Chacha. I just want to give him one message, that whatever I am is because of him, and he is being missed every single day. Thank you so much, guys, and I wish you good luck.